here. And thank you everybody for being here. We are so excited to have Dr. Margaret Jastreboff and Dr. Pawel Jastreboff here today to share their experience. This is the 25th anniversary of the term misophonia being coined. So let me first introduce them, and then I'm going to turn it over to them for their presentation. So first, for Dr. Margaret Jastreboff, she has been involved in tinnitus and decreased sound tolerance research since 1984 and on a full-time basis since 1991 while working at the University of Maryland School of Medicine. Her experimental work encompassed the study of mechanisms of tinnitus using molecular biology, pharmacology, and behavioral techniques, including testing drugs for their effectiveness for tinnitus attenuation. She's been involved in clinical work for over 30 years, while working first as an associate professor at Emory University, later as a visiting research professor at Towson University, and currently at JHDF, collaborating closely with her husband, Pawel Jastreboff. In 2001, she proposed a concept, name, and treatment for together, the two of them together proposed a concept, name, and treatment for a specific version of decreased sound tolerance, what we call misophonia, when patients exhibit negative reactions to specific sounds for a given patient patterns for given patient patterns of sound. After over 35 years in academia, where she was involved in basic science and clinical research, teaching audiology doctoral students and treating patients, she became the president of JHDF, a nonprofit foundation dedicated to research and education in the field of tinnitus and decreased sound tolerance, as well as treating patients. In 1993, she shared with Dr. Pawel Jastreboff Robert W. Hawks Award for her contribution to the field of tinnitus. She organized over 50 courses on tinnitus retraining therapy in the US and over 90 courses abroad, and she is the co-author of over 65 papers and 100 abstracts. Pawel Jastreboff, Dr. Pawel Jastreboff is currently Professor Emeritus of Otolaryngology, Head and Neck Surgery at Emory University School of Medicine in Atlanta, and he's visiting professor at University College London in the UK. He's a founder of the Jastreboff Hearing Disorders Foundation, where he continues his research on tinnitus and decreased sound tolerance, and provides clinical services to patients with a variety of hearing disorders. He continues to be involved in teaching professionals, including providing intensive courses on the management of tinnitus and decreased sound tolerance with TRT, which is tinnitus retraining therapy. And he has thus far offered more than 50 courses in the US and over 90 internationally. Dr. Jastreboff is recognized for his development of the first accepted animal model of tinnitus, the neurophysiological model of tinnitus, and based on his clinical method of tinnitus and DST treatment, which I've already mentioned is called TRT, tinnitus retraining treatment. Furthermore, collaborating closely with his wife and colleague, who I just introduced, he proposed together with her a concept name and treatment for a specific version of decreased sound tolerance. Again, this is misophonia, why we are all here today. And Dr. Jastreboff received a PhD in neurophysiology and a Doctor of Sciences degree in neuroscience from the Polish Academy of Sciences. He then did his postdoctoral training at the University of Tokyo in Japan, a place I know he loves quite dearly. He received an MBA after this from the Goizeta Business School at Emory University. And he has been a visiting professor at University of Tokyo, at Yale University, and an adjunct professor at Salus University, teaching tinnitus and hyperacusis in their audiology doctoral program. He is a co-author of over 150 papers, 180 abstracts, and 3 books. In 1993, he received the prestigious Robert W. Hawks Award for his contribution to the field of tinnitus, and in 2014, at 11th International Tinnitus Seminar, the Award for Clinical Excellence for 25 years of work in TRT. With that, I turn it over to the two of you. Thank you so much for introducing this term to the world and for what you're about to share with us. Dr. Jastreboff.
Thank you very much for this kind introduction. I have given 10 minutes to say how all these things started. This is a very frequent questions over the years we have. So 30 years ago, I started to be involved in helping tinnitus and hyperacusis patients at Emory Clinic. And since tinnitus is rarely reported complaint with children, our clinic was focusing predominantly adults, but it does not mean we did not have teenagers, and we have some children as well. Significant proportion of tinnitus patients complain about sound tolerance issue. It's estimated about 60% of tinnitus sufferers complain about sound tolerance. The point is that there are also patients who do not complain about tinnitus at all, and they were coming to our clinic with complaint of something what during this time, 30 years ago, was known as a hyperacusis. They mostly were reporting being sensitive on not being able to tolerate loud sounds, and some of them specifically were using word I am afraid, I'm fearful, and then they were considered as a phonophobic patients. During the initial interview, I noticed that many patients did not complain about louder sound. They rather they wanted to talk about soft sounds, about specific sounds, frequently in particular place produced by one or several, but very specific people. And what was happening that they were absolutely ignoring or tolerate the same sounds produced by other people in different situations, as well as they were tolerating loud sounds. So it did not fit really description and teaching I got from the specialist, because I was mostly in research lab with animals. So I've learned everything what I knew at the beginning from people who already were treating the patients. It was not fitting description of hyperacusic patients. So I spend a lot of time with patients being a little bit insecure and not being sure which kind of questions to ask and how they ask the questions. And I allow patients to talk. In case of younger people, I frequently was asking if I could talk by themselves without parents. Some parents were agreeing with this, and this was also very, very interesting experience, since many children had problems with some sounds related to the parents, and because they love their parents, they were not ready to talk really about all details in a way they were feeling. What also was interesting that some of the people reacted not necessarily to sound they were perceiving, but they were looking from the distance from home, and they were seeing, for example, lawnmower in a neighbor place working, and they were reporting exactly same reactions as they were exposed to sound. The complaints of the people were very similar. Those whom right now we know have hyperacusis, and those which now we are qualifying as misophonic patients. They were annoyed, they were unable to enjoy many activities in life, they had problems with concentration, with sleep, sometimes experience emotional problem, anxiety, sometimes depression, physical discomfort. They were not able to control their reactions. They were frustrated. They were worried. They were afraid. One of my first patients, I think that this would give you quite good idea how all these things were working, and you will be identify yourself or your loved one. One of my first patients was a young man in his 20s. His main complaint was clicking sound. He had a problem in college, earlier at school as well. And particularly when he was put in a quiet room and had to uh, deliver some, answer some questions, so it was exam. What has happened that many students were clicking the pen, and this was extremely difficult for him. But actually, it did not start it from clicking the pen. It started, what is not very common, from his own sound. Uh, in high school, he was a runner, and at age about 15, 16, he started hearing clicking of his own knee. This probably also associated with worry that he will not be able to run, was causing a big problem for him. The parents took him to orthopedic surgeons. Everything was checked. It was just regular fluid and movement of joints, no problem. So, physical therapy, no problem. Then he had contact with some psychologist who was also helping him with dealing with the problem, but actually problem did not diminish, but actually was growing up. So these clicking pens. Then it was coming to the summer, and there were some beetles which had rhythmic type of the clicking he was hearing, particularly during late afternoon, and it was really very difficult for him to deal with these problems. So his problems were actually expanding. And what was also interesting, when he entered the room, he had headsets on his phone, on his head, and music so loud that one could hear this from the distance. So another patient was a teenager, a girl living with a single mother, and she start to complain about her mother eating. So, not to make a detailed description, it ended up that one started eating in a kitchen, the other one in the room. And the girl did not have any problem with her friends at school or even with her aunt, because for some time, mother sent her to live with the aunt because it was so much tension at home and no problem with the aunt. And the girl said, my mom, it's so loud. She's always eating with open mouth and she's talking, and all this is disgusting. Later on, she started even having problems with her mother breathing or moving her hand on certain surfaces. She was stressed, she was frustrated, and when she talked about this thing, she was crying. She loved her mother, she wanted to be with her, but she was not able to deal with the problem. But these were pretty common type of situations. The main break was with a critical moment with 30 years old, 30 plus years old executive in New York who came with the complaint of not being able to enjoy and be in restaurants with his friends and with his clients. And he was repeating several times, I'm scared to go to the restaurant. So it is noisy, people are talking, people are not polite, people are not respectful. When, after testing, I stated to him, most probably you have phonophobic type of reaction. He get up and he was ready to leave. He almost screamed at me and he said, I am not fearful of restaurants. I am simply so uncomfortable that it makes me to react the way I'm reacting. So, therefore, we decided that we have to call this type of a problem some way. And we coined the term misophonia, not going into detail. Miso means hate in Greek, and but you should not really translate this literally. Like you are not translating the word photography as drawing with light, or chromatography, drawing with color. It is just a word which is describing negative reactions, negative emotions which people are expressing during counseling. And what is the conclusion from all these things? Misophonia was only noticed and discovered because I was really without any particular attachment to hyperacusis or phonophobia, and I was listening to the patients. Things were not fitting whatever I was taught, whatever eventually was written, uh, not much in a textbook, but nevertheless, these things were mentioned. And I think that the saying of Dalai Lama is really applicable to here. When you talk, you are repeating already known things, but when you listen, you are learning something new. And this is what has happened. So from this time, we carefully adjusted and changed our treatment, which always include educational counseling, talking about sound, doing certain exercises with sound, and very frequently we were using also some devices which were very helpful to people. By saying all of this, I want to state misophonia is not problem only of children. Our elderly oldest person was 80 something years old, and she started having a problem in her 60s and not able to link to anything in a childhood. More we are seeing children and young adults with this problem, but nevertheless, they are people who, older people who have this problem. And I want to finish these few words I said by just a statement from about few memorable patients. This was a girl who came for last appointment when we were closing her files with pamphlets in hand. One for patients, one for family members, one for the doctors. She wanted to share her story with others. She was living in a quite large city, and she was distributing this to the offices of other people. She wanted people to know that there is help available. The other one was the patients who sent a postcard, waiting for the trip for 10, 15 years and unable to do it. Finally, she went and sent a happy card for us. Another patient at the end of the treatment went to movie theater and was watching the movie, same movie, 3 times in a row. So, and the father brought children who were with grandmother because he was not able to stand their voices even with soft talking. So there is help. There are ways to help patients, and this is how all these things started. And now a few words from my husband.
Uh, well, into a little shift over time. I don't know how much time you have left, and I would appreciate if organizer let me know like 2 minutes before my time is done to let me know so I can
Sure.
just cut remaining of presentation. And how many minutes more or less I have now?
You have 8 minutes.
8 minutes. Perfect. So thank you very much for very kind introduction. And I think it's very important that you heard from the horse's mouth how the story of misophonia started. And indeed, it was because Margaret was listening to a patient and wasn't biased by any kind of a preconception. So once with the misophonia, with a term, I was thinking, well, how it might be, what are potential mechanisms, and what to do about this. And without going into detail, because it will take probably a day, I would like to tell you that the final conclusion from all information from the patients and all my knowledge as a neuroscientist was that misophonia is due to enhanced function connection between auditory and emotional, limbic, and autonomic nervous system. And it is even possible to localize, to point out certain structure called medial geniculate body and certain subnuclei in amygdala, which is one of the main structure of the limbic emotional system, as a responsible for this. Now, I would like to make some general comments. We strongly disagree with classifying misophonia as a psychiatric disorder. And it was from very beginning, we believe that misophonia, for example, can exist with all the system of the brain functioning in normal manner. And problem arise from subconscious connection based of conditioned reflexes, function connection to specific patterns of a sound. And you have to consider not only auditory system, but other sensory system in the brain playing a role. What we now know that actually misophonia is more popular than we initially estimating, that about 4% of general population has misophonia requiring treatment, requiring help, but different severity of misophonia from very, very mild to extremely severe, but about 4% general population. If you have a severe misophonia, it can totally control patient life, causing the patient are unable to work, unable to leave a house, and when the house arrest. Hyperacusis has a different mechanism. I'm not going to talk today about hyperacusis, but which cause that the treatment for hyperacusis is different than for misophonia, and what works for hyperacusis is not working for misophonia. And we have strong data supporting this. I would like to mention a few things because one of the, I believe, misconception is that misophonia cannot be treated successfully. And actually, it turned out that it is possible to treat misophonia so successfully that we can have a cure. That means that misophonic triggers start to be totally irrelevant and are not evoking any reaction. And we are seeing this following patient for a few years, even up to 20. We published paper in 2014 showing that in the series of 184 consecutive patients, 83% or in 83% of the cases were able to treat misophonia and achieve clinically significant, not statistically, but clinically significant improvement. And since it was still is discussion regarding possibility of cure for misophonia, we'd like to demonstrate the proof of concept, just a few cases. And this case is one of the first, actually the first patient, I think, who got treatment for misophonia. What's interesting like this, that I was trying to treat him for 7 years with a diagnosis, which turned out to be misdiagnosed in 1993 as a hyperacusis and tinnitus. And I was treating him to the best of my knowledge, and to my surprise, nothing helped. But at this time, please remember, we did not realize that misophonia might exist. And what was interesting, we had a number of weak sounds, water, voice of people, paper crying children. And when he was exposed to sound, with exposure to sound worsened, decreased sound tolerance, we now know, misophonia, for days. And so one of the actually feature which are observing in misophonic patient. And as a result of it, it was so severe that he was in house arrest for previous 10 years. He wasn't able to go out. At the same time, this is an audiological measurement showing how well people are tolerating loud sounds, and his LDLs was 60, so it was definitely much lower. It should be around 100. So he had a problem even if we're looking at the audiological measurement. So he was treated for 7 years and 9 months because when he came again to clinic, initially I was still treating him with the updated version of hyperacusis, and nothing worked. But once he started being treated, and I used the first protocol for misophonia, after 1 month, we start seeing improvement, and then it was further very rapid improvement. Case closed for 36 months, but I was following him for next 20 years. Final score on our questionnaire, all zeros, no problem at all with previous misophonia trigger.
You have
With
1 minute left.
okay, loudness discomfort level 110, no problem with tinnitus. And what is interesting, those are, quotes, verbatim quote from a patient. It's like being in jail for 10 years, now I'm out of jail. First time I was in movie theater after 10 years, I have tears of joy. Stayed for free session. Family friend, no problem. Well, thanking for restoring life. Wonderful. I'm feeling great. You gave me my life back. So I skip another cases who have many more cases like that, and I'm preparing now, uh, trying to do this publication from this. But I would like to point out, misophonia can really control life patient. Misophonia, average misophonia is worse than severe tinnitus. Treatment needs to be highly individualized, more individualized even but in case of tinnitus. And it is possible to achieve total removal of reaction to all previous misophonic triggers, a cure. And I would like to return to this patient, but we are following him until now. This patient is sending us this Christmas cards and so on. And we stopped treating him in 2002 or 2003, and we have a 2026, he's still fine. Thank you very much for your attention, and I hope it will be helpful.
Thank you so much, Dr. Jastreboff and Dr. Margaret Jastreboff. Thank you so much for everything you've done for the field, and thank you for your time and your wisdom today. We are all so grateful. You can see the many hearts and likes and everything popping up here. Thank you so much. We're going to now end this session and